finding more hair in your brush than usual, noticing a wider part in the mirror, or realizing your ponytail feels noticeably thinner than it used to are experiences that millions of women share after the age of 50. The distress these changes produce is real, and so is the confusion that often accompanies them. The hair loss supplement industry is enormous and largely unregulated. The advice circulating online ranges from helpful to completely inaccurate, and many women spend months trying products or following recommendations that are not matched to what is actually causing their particular hair thinning. Understanding the biology behind age-related hair loss, distinguishing between the two main types that affect women after 50, and knowing what the evidence actually supports is the foundation for making informed decisions rather than guessing. The encouraging reality is that most hair thinning in women over 50 falls into one of two well-understood categories, and knowing which one applies to your experience determines the appropriate response almost entirely. Female pattern hair loss, the gradual kind. Female pattern hair loss, also known by its clinical abbreviation FPHL, is the most common cause of hair loss in women according to the American Academy of Dermatology. It tends to become more noticeable with age, and particularly around and after menopause, when the hormonal environment that has supported hair growth throughout adulthood shifts significantly. The appearance of FPHL is distinctive once you know what to look for. It typically manifests as a widening part and diffuse thinning over the crown and top of the scalp, rather than in isolated patches. Ponytails feel lighter and less full over time, and more scalp becomes visible on the top of the head. The defining characteristic of FPHL is that it is slow and progressive. Hair does not fall out in sudden clumps. The change unfolds gradually over months and years, in a way that can make it genuinely difficult to recognize until enough accumulation has occurred to become noticeable, often prompting women to look at older photos and realize the shift had been underway for far longer than they had registered. This gradual nature is one of the reasons FPHL is frequently underdiagnosed or misunderstood. By the time most women notice it clearly, the pattern has been developing for some time. The underlying driver is the relationship between hormones and hair follicles. Hair follicles are sensitive to androgens, the group of hormones that includes testosterone, and as estrogen levels decline during perimenopause and menopause, the relative influence of androgens on hair follicles becomes more pronounced. This shift causes follicles in the affected areas to produce progressively thinner, shorter, and lighter hairs over successive growth cycles. Telogen effluvium, the sudden kind. Telogen effluvium, abbreviated as TE, is an entirely different experience from FPHL and is frequently confused with it because both result in more hair being lost than usual. The critical distinction is in the pattern and timing. TE involves rapid, diffuse shedding rather than gradual progressive thinning in a specific area. Women experiencing TE typically notice significantly more hair in the shower drain, on their pillow, and in their brush, with the shedding distributed broadly across the scalp rather than concentrated on the crown and top. TE is triggered by a physiological stressor that pushes a larger than normal proportion of hair follicles out of their active growth phase and into the resting phase simultaneously. When those follicles shed several months later, the volume of hair loss can be alarming. Common triggers include illness, surgery, significant emotional stress, hormonal shifts such as those accompanying menopause or changes in thyroid function, and nutritional deficiencies, particularly in iron, ferritin, and vitamin D. The delay between the triggering event and the noticeable shedding is one of the most confusing aspects of TE. A woman who had a serious illness in January may not notice significant shedding until March or April, making it difficult to connect the two events without understanding this biological timeline. The reassuring aspect of TE is that it is usually temporary. Once the underlying trigger is identified and addressed, regrowth is common, and most cases of TE resolve without permanent hair loss. Telling the two apart, because the appropriate response to FPHL and TE differs substantially, being able to distinguish between them is practically important. FPHL presents as a gradually widening part, thinning concentrated on the crown and top of the scalp, a progressively lighter and shorter ponytail, and a pattern that has been developing slowly over time. The scalp may be more visible through the hair, but generally looks healthy. TE presents differently. The shedding is sudden rather than gradual and is diffuse across the whole scalp rather than concentrated in a pattern. There is typically more hair than usual appearing in the brush, shower drain, and on the pillow. The shedding usually began or intensified after a recognizable period of stress, illness, or significant life change. The scalp itself typically looks normal and healthy despite the increased shedding. When the pattern is ambiguous or when both types seem to be occurring simultaneously, professional evaluation becomes particularly valuable. What actually works for FPHL? For women dealing with female pattern hair loss, topical minoxidil is the most evidence-backed over-the-counter treatment available. A large randomized controlled trial found that 5% minoxidil was significantly superior to placebo for hair growth outcomes in women with FPHL over a 48-week study period. It has FDA approval for use in women and represents the standard first-line recommendation from dermatologists for this condition. The most important thing to understand about minoxidil is the time frame required for results. This is a treatment that operates over months, not weeks. Consistency of application matters more than the specific formulation chosen. Women who apply it irregularly or discontinue it after a few weeks without seeing dramatic change are unlikely to experience the benefit that consistent long-term use produces. The treatment needs to become part of the routine in the same way that other daily personal care habits are, with the understanding that meaningful visible results typically require at least 3 to 6 months of consistent use. What works for telogen effluvium? The approach to TE is fundamentally different from the approach to FPHL. Because TE is triggered by an underlying stressor rather than by a progressive hormonal and follicular process, the primary intervention is identifying and addressing the trigger rather than applying topical treatments. If the trigger was an illness or surgery, time and recovery are often sufficient for hair to regrow. If stress was the driver, managing that stress and allowing the body to return to equilibrium supports regrowth. Nutritional deficiencies are among the most actionable triggers because they can be identified through blood testing and corrected through diet or supplementation. Doctors evaluating persistent shedding commonly check thyroid function, iron and ferritin levels, and vitamin D, all of which can contribute to TE when they fall outside optimal ranges. Correcting identified deficiencies often produces meaningful improvement in shedding within a few months. 2 myths worth correcting. 2 widely circulated beliefs about hair loss deserve to be addressed directly because they cause unnecessary alarm and lead people toward unhelpful responses. The first is the belief that washing hair causes hair loss. It does not. What washing does is release hairs that are already in the resting phase of the growth cycle and would have shed shortly regardless. Seeing these hairs accumulate in the drain can be alarming, but the act of washing is not causing the loss. Avoiding washing to prevent hair loss is not only ineffective but counterproductive for scalp health. The second myth is that a single supplement can comprehensively fix hair thinning. Supplements can be genuinely helpful when a specific nutritional deficiency is contributing to hair loss, because correcting the deficiency removes a real obstacle to normal follicular function. But in the absence of an identified deficiency, the evidence for most supplements producing meaningful hair regrowth is weak and inconsistent. Products that promise dramatic results without first establishing whether a deficiency exists are almost certainly overstating what they can deliver for most users. When to see a dermatologist? Some presentations of hair loss call for professional evaluation rather than self-directed treatment. Patchy bald spots rather than diffuse thinning, scalp discomfort, burning or scaling, rapid worsening over a short period, and hair loss accompanied by systemic symptoms including fatigue, weight changes, or menstrual irregularities all warrant an appointment with a dermatologist. These situations may reflect conditions beyond FPHL or TE that require accurate diagnosis and specific treatment.